Good afternoon, everyone, and welcome to this webinar from the Health Foundation on what it will take to bring improvement from the margins into the mainstream. My name is Malte Gerhold. I'm the Director of Innovation and Improvement at the Health Foundation, and I'm going to chair and guide us through the conversation with our wonderful panelists today. Let me start with a bit of housekeeping. This event and webinar is being recorded, and the video will be made available on our website in the next 24 hours. Also, there will also be a subtitled version for our audience. We will be taking questions throughout the webinar. Please put your questions into the Q&A box at the bottom of your screen there to submit. You can also upvote questions that you would like to see answered or find particularly interesting with the thumbs up icon in the Q&A function. And we will try and answer as many questions as we can, and certainly the most popular ones when we get to the Q&A in the session. Also, if you've already submitted questions as part of your registration, we have a list of those, and we'll also bring those in as part of the Q&A in the session. And then finally, if you want to tweet about this event, you can use the hashtag NHS Impact. Great. So a bit more about this webinar and the topic before I introduce our panel members. We all know that the NHS is facing an unprecedented range of pressures on our workforce, on finances, on recovery. And I think staff, leaders, clinicians, managers are looking both nationally and locally for what is the right strategic approach that can help us to maximize how we make progress, but also how we can spread and get the most benefit from good ideas, innovation, service improvements, including new technologies. And NHS Impact, the new NHS improvement approach that was launched by NHS England earlier this year, is intended to help meet this particular need and support how we improve. And a lot of it will depend on how we implement it going forward. Now, this is not the first time that we have an approach towards improvement across the NHS in all levels and all organizations across places. But it is an important moment in our time to make it really part of the mainstream with success. Now, what will it take to do it this time? How do we overcome the pressures that we all face, some of the skepticism maybe to what has been done before on improvement? And how can we get this right, both with all our practitioners and staff and patient, but also the leaders and politicians to support this approach and make improvement a mainstream principle of the NHS? So this webinar will be exploring different perspectives towards that and how we tackle the challenge of prioritizing improvement and do it differently this time in a system under pressure. Right, with that, let me welcome our wonderful panel. First of all, Elsa Brotherton, who's the Executive Director of Improvement, Research and Innovation at Lancashire Teaching Hospital, NHS FT, and who is also the newly appointed Director for the National Improvement Board that underpins the work of NHS Impact that was set up by NHS England. Elsa, if you want to say hello.
Hi, everyone. It's great to be with you this afternoon.
Fantastic. Thank you. Great to have you. And then next, David Fillingham, who is the chair of the Lancashire and South Cumbria NHS Foundation Trust, and also the chair of the NHS Improvement Board that was recently set up for NHS Improvement. David, if you want to say hello.
Hi, everybody. Nice to be here.
Thank you, and good to have you, David. Next, Neil Goulburn, who is the Chief Strategy, Partnership and Transformation Officer at Lewisham and Greenwich NHS Trust, and is going to tell us more about his personal experience with this work. Neil?
Hi, Walter. Hi, everybody. Great to be here.
Thank you. Wonderful. And finally, Penny Pereira, the Managing Director of our Q initiative at the Health Foundation. Penny?
Hello, great to be here.
Great. Now, we're going to structure this webinar in two parts. We're going to start, first of all, with a presentation from David and then Penny that will set the context on improvement, the NHS Impact approach, and then have a bit of time for questions. So that'll be about 20 minutes to hear from David and Penny, and then about 10 minutes or so for your questions. And then we move on to the second part where we will hear from Elsa and Neil about the work that they've been doing and the challenges and solutions they've been finding locally with their teams and organizations in place. And again, that'll take about 20 minutes with about 10 minutes for questions afterwards. As said, please put your questions down in the chat as we go along and as you hear from our panelists, and we'll look through those and bring them up as part of the Q&A section. So with that, thank you very much again for joining, and I hand over to you, David. Thank you.
Well, thanks, Mal. Hello again, everybody. I was delighted back in August to have been appointed as the first chair of the new NHS National Improvement Board. But as Malt said, I am also the chair of Lancashire and South Cumbria Foundation Trust, and we deliver mental health, learning disability, autism, some physical community health services to nearly 2 million people up in the northwest of England. And just to show that I am connected to the pressures on the front line as part of my day job, I'm afraid I can't be with you for the full session today. I need to leave at 5 to 3 precisely, because we have CQC weathers for our well-led inspection this week, and I have the great pleasure of joining CQC at 3 p.m. to discuss well-led in our trust with them. So apologies that I won't be with you for the whole session, but you'll have me for my slot. Looking forward to listening to Penny and then for the discussion as well before I do need to leave to join CQC. So I just in 10 minutes then, 3 things from me. The first is to say, so what is NHS Impact and what is our vision for what it's going to deliver right across the NHS? Secondly, how are we going to go about that process over the next 5 years? And particularly how we're going to face up to some of the really big challenges that we face in making this a success. And then finally, I'm thrilled to see the scale of attendance we've got on this webinar. I know a lot of people have shown interest and signed up. And I hope that's not just an academic interest. I hope you're signing up because you want to be involved. So my third point is going to be, so what can you do to make this a success? I would hope and expect many of you do know a bit already about NHS Impact, but just as the reminder, it's a shared approach to improvement across the NHS as a whole. And quite handily, given the title for this webinar, it is all about moving improvement into the mainstream. It is all about making sure that improvement is the way we do our work every single day. It came out of the Delivery and Continuous Improvement Review led by Anne Eden, and the National Improvement Board has been set up as a part of that. But let me be clear what it isn't. So it isn't about everybody in the NHS using exactly the same improvement method. And it isn't about this having to be branded in the same way in every trust, in every place, in every system. We want to encourage local innovation and local ownership. What it is about recognising that the evidence base that says that there are 5 clear components that form the DNA of an improvement culture. And those are developing a shared vision and purpose that runs right through our organisations and systems, that's owned by everybody. It's about investing in people and in our culture so that we have a culture that actively supports and empowers people to improve the work we do. It's about having leaders who will work in an improvement-focused way. Yes, it's about using a robust suite of improvement methods that may be different in different places at different times. And critically, it's about embedding all of that, both in our management systems and processes, but embedding it in our daily work. So it becomes, this is how we run our organisations, this is how we run the NHS. That's the vision, and it's an ambitious vision. And it's not a hobby, it's not a nice to have an add-on at the margins, as the title of this presentation says. It's about delivering results, and it's about delivering results across the whole of the quadruple aim. In 5 years' time, I would fully expect to see us being able to point to improvement action on the ground that has improved health outcomes, reduced inequalities in our communities, has definitely improved the quality of care for patients, giving us a better use of the taxpayers' money we've got, and giving much greater joy and pride in work for the colleagues who work in the service. That's what we're about. And in order to achieve that, every provider organisation, every primary care network, place, integrated care system will have its own local approach, its own system and culture of improvement. And we will also be applying improvement towards our biggest challenges. So whether that be patient safety, emergency care, electives, primary care access, mental health, the success that we're having in delivering results will have improvement at the heart of it. Which is an exciting vision, which kind of begs the question, so how are we going to do this? And I've spoken to a lot of groups lately, and as improvers, I think we need to listen very honestly to some of the challenges and understand how we're going to overcome them. So the first is, isn't this the wrong time to do it? Malt said in his introduction, huge financial pressures right across the system, workforce pressures, demand that we're struggling to cope with, industrial action, it feels like a difficult time to be getting this off the ground. As you may be able to tell, I'm a Foundation Trust chair these days. I've lost all the hair during my NHS career, and I can remember the 1990s. Not many people will, but you know, when we created the NHS plan in the year 2000, the context of the NHS was very similar to now. Big deficits, very long waiting times, really poor outcomes. But at that point, we didn't have what we have now, which is thousands and thousands of people who've been trained in improvement, and many organisations who are putting improvement at the heart of what we do. So yes, the context is challenging, but I actually think we're in a better place now to move this forward than we were in the early 2000s. Second thing I would want to say, though, is that delivering on this is not just about the improvement enthusiasts. If this is going to work, it's got to be led by whole boards, and in particular, we need chairs, chief executives, directors of finance, chief operating officers, to be seeing it as their job to build this local system and culture for improvement and put it at the heart of the work that they do. And of course, that isn't easy. And I'm off to meet the CQC at 3 o'clock. I know full well the pressures on organisations. And so we've got to encourage and inspire people to do this. You can't performance manage an improvement culture into the NHS. But we will be very actively encouraging all boards to complete the self-assessment that we've developed around those 5 domains. We're not going to be asking them to send us the returns. This is for them to reflect with humility on their own position and create a development plan. We'll be asking ICBs and regional offices to facilitate and support that and encourage all boards to do it. We'll be building this into chair and CEO inductions and development programs, and we'll be working with the service to co-design a set of development opportunities, particularly for boards, about their leadership role in building systems and cultures for improvement. And finally, and I may mention this to our CQC inspectors at 3 o'clock, we need to reflect this in the CQC inspection regime. Well-led has to have this right at its heart. And then finally, people say, where's the improvement expertise and capacity going to come from? We've got hundreds of people who've signed up for this webinar. We've got thousands of people across the NHS who've been trained in improvement skills. We've got countless organisations now with great examples of relatively small scale, sometimes, improvement at the local levels. So we've got the ingredients. What we've got to do is deepen and multiply that, and really put it at the centre of everything that we're doing. So yes, there are big challenges, but I think we can see, and this won't be easy, but I think we can see a really clear path where we can get concrete improvements in the short term, in the here and now, which will build and build and build and grow towards that 5-year vision that I described at the beginning. So what can all of you do? You've taken a first step, I think, by signing up to this webinar, but be curious, I would say, learn more, get on the NHS Impact website, find out more about it. There are a lot of different events and networks discussing this at the moment. Take part in that, and bring your own perspective into the room. Then get involved. I hope we're going to see many more opportunities for colleagues at every level to take part in improvement activity in the coming months, and you just put your hands up to be a part of that. And finally, from the NHS Improvement Board's point of view and NHS Impact more widely, we want to learn from what's going on in the service. This isn't NHS England Impact, this is NHS Impact. This is the NHS working together to make a real difference. So we need your stories, your reflections, your lessons. We need to understand what's worked. We need to understand what some of the challenges are. And we need to understand what kind of support and help is going to make the most difference. I think this is a huge opportunity, the greatest opportunity I've seen, I think, in the last 20 years to really put improvement right at the heart of everything we do. And it's up to us all to seize that opportunity. Thank you, Mal.
David, thank you so much for that overview, and also the emphasis on the intention and the ambition to make this an approach for NHS staff and with NHS staff throughout in a movement over time, which is fantastic. A quick reminder, please put questions into the questions box if you have any, and we'll come to it after our next speaker. A couple have already come through, so please continue to do that. And with that, over to you, Penny.
Thank you. Around those slides, Caroline, thank you. So I'm going to build on the NHS Impact vision that David's just been talking about. I'm going to unpack some of the key shifts that we're going to need to make to get there. The Health Foundation is going to be publishing more on this in a couple of weeks, drawing on the evidence I guess we've helped to build over the decades that we've been supporting continuous improvement. For improvement ideas and approaches to be mainstream in the way that NHS Impact is proposing, we're going to need to be thinking more broadly about where they can make a difference and the benefits improvement brings. And we need to understand what boosts efforts to embed improvement principles and what gets in the way. So let's just start by stripping back what we mean by improvement to some simple principles which underpin not just that kind of rightly ambitious DNA of improvement in NHS Impact, but also the highly varied work happening in every organisation that we can therefore build on. Improvement science is a broad field of ideas and approaches. What they have in common is taking a kind of system view of challenges and solutions, a commitment to co-producing with those who need, use and deliver services, working iteratively, typically gathering and acting on data as real time as possible. And improvers learn that context matters to what you can achieve and whether it will last. So work often includes building the capability and culture to support change. I lead Q, the Health Foundation's community of more than 5,000 people collaborating to improve health and care, supported, co-funded by NHS England and our country partners across the UK and Ireland. Q is pretty unique in its scale, and it gives us a kind of window on what those tasked with transforming services are doing. I've been working in this field for over 20 years, and in that time I've seen improvement ideas used in an ever wider range of ways. So the type of improvement that might come to mind first are QI projects, typically led by clinical teams to tackle specific service issues. This is how we've made progress on many safety and access problems over the years. Almost all organisations will have work they can build on here. And then, of course, many healthcare challenges cross organisational boundaries. So there's also improvement work happening on a more ambitious scale to transform pathways or models of care. And then there are also lots of specific innovations or efforts to achieve particular goals that might cut across formal hierarchies. Improvement methods are helping make sure those innovations are targeted where they'll have most difference and support them to embed. I guess what we've learned over the years is that to enable that kind of project-focused work to scale and last, we need to develop the organisational context to be more supportive. So while a bit less widespread, as David says, there's a growing number of places that are embedding improvement ideas as a kind of core way of operating. To me, this is the key strategic contribution area of NHS Impact. Like, inspired by the results of those leading organisations, it's really emphasising the need to create the conditions where those kind of isolated projects that we've been seeing for years will kind of come together and have much greater combined impact. Through Q, we're seeing a lot of interest and activity in that kind of level of work. So, there's plenty to learn on. So I guess the first point is, when thinking about how to make improvement more mainstream, let's make sure that we're appreciating the many kind of different ways in which these ideas are already being used and how we can build on that. I guess if your organisation is still assuming that improvement is just about small scale projects using PDSA cycles, then it's going to be missing a lot. In parallel with then thinking broader about where improvement can be relevant, a mainstream approach, I think, leads us to think more holistically about the benefits. So to use an example, when I guess I first started out doing improvement in the early noughties, I was involved in work to improve flow through outpatient care. Our work was pretty typical. It was project-based. I was reporting on, supporting particular waiting time targets that were important to the sponsor. I guess because we were using improvement methods, that did mean that we were designing changes in a way that brought other experience and safety benefits, and in the process supported teamwork and job satisfaction for those involved. So it's giving us benefits in advance of the patient outcome showing, which helped maintain momentum. And reduce waste, although I'm reflecting it was a different time, we didn't like to talk about that. We also didn't talk explicitly about inequalities, something that these days is the focus of a lot of promising energy and activity within the improvement world. So taking a holistic approach means that their solutions are more likely to last than the kind of short-term fixes focused on a single target that I think we too often reach for in the health sector. once we get over thinking of improvement as narrow projects, there's so much that these core ideas can help with. While improvement's systematic, it has a bit of a bias to action, to learning as you go rather than taking months planning. So if you have stakeholders that are dismissing improvement benefits as a bit too slow in coming, then you might want to help them see this differently. Improvement, it allows us to make better use of the time and resources we have. Done well, we're targeting effort more wisely, and we're using effective approaches to change, which are more likely to deliver over the medium term. I guess a broader view of the benefits helps improvement become more mainstream by building ownership across different stakeholder groups and agendas. So it's not just the domain of enthusiasts, as David was saying. The best places are recognising that the kind of system analysis, the change skills that improvement offers, they're an indispensable capability that's needed to deliver an organisation's goals. They're not sufficient in itself, but a really core part of the mix that are needed to realise the benefits of, say, any major IT or workforce change, or to make sure that we're reliably delivering day to day. We're going to be publishing a quick guide to the evidence for the benefits of improvement, touching on all of these areas kind of shortly. I guess when there's such need in the health sector for us to make more of the idea and resources that we've got, and improvement can help us meet our goals in so many different ways, from short-term problem solving to longer-term transformation, why is it that improvement ideas and expertise are still pretty marginal in most places? Why is it that we're needing something like NHS Impact to bring this higher up the agenda? Well, to add to what David was saying, I guess the reality that we're picking up is that understanding and experience of improvement, it is uneven. My job brings the privilege of seeing examples all the time of really successful, satisfying, rigorous improvement. But for all success stories, it's sometimes done badly, or the language of transformation is used without the principles and rigour and supporting resources to underpin it. I think deeper than this, there are different mental models for how change happens in the health sector and how quickly we can expect results. Much as the idea of a silver bullet solution, it's seductive, especially when the pressure's on. In practice, when you're talking about bigger changes in complex social systems, that is going to need a pretty advanced set of technical and relational skills, leadership habits. It's going to require you to diagnose issues properly and redesign a service. An iterative approach to change is quite a pragmatic way to delivering at a decent pace in a complex system. But that way of working can mean that it's quite difficult to isolate cause and effect and to, say, commit in advance to delivering a set of results within a certain time frame. And so that way of working creates tensions with the prevailing performance management culture and expectations in service. Ironically, by insisting on quite a rigorous, sustainable approach that's grounded in the reality of how change happens, improvement's sometimes seen as not really fully engaging in the reality of the big pressures facing organisations. There's plenty we can do to address these barriers, of course. Building and connecting the expertise that exists within organisations and systems can help people share skills and knowledge, help the benefits of improvement be felt in the many places where it's relevant. If we're to take these ideas wide, weave them together with improvement with other disciplines, I guess we're learning through Q that we need to build collaboration skills in parallel with the skills you might more often associate with improvement. The evaluation of the VMI programme that was published last year, next slide, shows nicely the critical role of flexible connections between people to enabling the shifts in culture and practice and the skill sharing that will be needed for improvement to become more mainstream, for NHS Impact to have the ambition that it needs. It's beyond the time that we've got to go into this in detail, but in brief, this analysis shows people represented by dots and the nature of their connections through the lines. The evaluation shows how investing in enabling sharing and collaboration appears to contribute to overall performance. That feels particularly exciting to me, as we know from the evaluation of Q that we're enabling similar kind of connections across organisations and professional groups at a massive scale, alongside the many other kind of vibrant networks that exist in this space that David was referring to. Politically astute leadership, I guess I'd also draw out as really important in mediating those different views of improvement, creating a shared vision. Leaders create the space for building the connections, the capability, the culture that's needed. They set improvement work up for success. The leaders in my room have obviously just decided the lights need to go off. They set improvement work up for success, focusing proportionate resources on well-planned interventions that are geared to delivering priority objectives. Local leaders need supportive system partners and national support to have greatest impact. I guess, as David's described, NHS Impact is creating that explicit national support in England. I guess it feels like there's no better time to be learning from those places that are further ahead on the journey, thinking about what next will be most important where you are. Yeah, that's it from me. I'm really looking forward to our discussion and hearing from Ailsa and Neil. Thanks.
Penny, thank you so much for that overview and summary, particularly what can happen at a place as well. So there have been lots of questions coming in, and I'm going to try and maybe bring some of them together so we get through as many as possible on what we just heard. And let me start with one from Catherine Dale, who says that in the past, most investment and improvement has taken place in acute trusts and hospitals. How do we might disperse this much more across all elements of the health and social care system? And then Sandra Bond followed up saying, what about social care? So many opportunities. And an anonymous question also about wider collaboration beyond the NHS and not just within the NHS. If I can maybe come to you first, David, on that question of how do we move beyond hospitals into the community and place?
So it's a great question, and I didn't have time to put it into my 10 minutes. So thank you to Catherine and others who've raised that question, because one of the things that I think is great at this point in time is with the development of integrated care systems, with moving away from the commissioner-provider split, the internal market model. I think we have a real opportunity to work in a joined-up way to bring together, of course, acute hospitals, but alongside community services, primary care practitioners, mental health, learning disability and autism, but critically working with our wider partners, most particularly with local authorities, not just social care and public health, of course, but if we're really interested in improving health and tackling inequalities, then with education, with housing, with community safety, all of the other things that make up for a thriving community. And I would absolutely hope and expect that whilst the title is NHS Impact, we will start to broaden out to engage with all of those wider partners. I also think that the problems and challenges that we have now, there's similarities to 25 years ago, but there's quite a lot of differences as well. And I think if we're really going to succeed in taking pressure off acute hospitals, then we've got to genuinely transform the way community services operate. I have to say, for the last period of my career, I've seen too many times where we've had programs called Transforming Community Services that have really been about transferring community services from one employer to another. That, I think the things that are in Claire Fuller's report around genuine integrated neighbourhood teams, bringing general practice together with physical and mental health community providers are totally the way to go. And I think the 5 elements of that DNA, the vision and purpose, the investment in people and culture, the leadership behaviours, the improvement method, and then embedding it, work just as well at the primary care network, at the place and at the ICS as they do in providers. But I think there are similarities and differences, and we need a conversation, a national conversation about what those similarities and differences are. We need people with system leadership skills, not just institutional leadership skills. We need a shared vision that's much broader than just the NHS. And frankly, we need a much more eclectic toolkit, if that's not mixing the wrong adjective with the wrong noun there, but we need a really broad array of approaches, including asset-based community development, population health management and others, alongside the traditional improver set of tools. So great question, so much to get into there, I think, and that's definitely on the development programme for NHS Impact.
Thank you, David. Let me come to the next question and ask Penny on that first. And also, Penny, if you then have something to add on this question around wider place, please do start with them. But it's a question from Emma Adams, who says that not all organizations can afford strategic partners to help them develop their approach. They can be expensive. What support might be available to help all those organizations? And Claire Fountain followed up also with a question, do we have a responsibility to use the NHS where we can or not-for-profit partners and not just commercial partners for that? Penny, do you want to start that? And then David, I'll bring you in on that one quickly too.
Yeah, great. And I guess just to flag first on the response around improvement across different sectors. I mean, the work in Kew and across the Health Foundation specialists, there's plenty of appetite in improvement outside of the NHS and growing maturity in that. I guess I just wanted to plug the other impact, the Impact Centre that the Health Foundation is funding to support the use of kind of research into practice around improvement in social care, and also through some work that we're doing with NHS Confederation, some principles that we've developed with people who are leading work at local system level, thinking about actually how do you work with the diverse groups and stakeholders with different methods across your local patch. So yeah, some particular guidance there. Yeah, thank you, Emma, Claire, for your point about how we make best use of the expertise that already exists within the health system, something that I and many others are really passionate about. I guess we are in a financial context where we can't afford to be relying on external consultants to do this work, and actually there's pretty good evidence that that creates antibodies within organisations. It can make for less sustainable change in the longer term. So there's certainly a place for support partners who have the kind of scale of some of the private sector organisations, but there are plenty of other resources that are available more within the NHS now. So there are some kind of NHS family support organisations like Aqua, your previous organisation, David. I think we need to be thoughtful about making the most of cultivating and supporting those support providers. And I guess through Kew, we know now that there are lots of people who have training and skills around improvement. So finding tactical ways in which we can help them use their skills to go where the priorities and the work is within the health system, I think that can be part of the solution too.
David, do you want to add to that from your perspective as well?
Just to build on it, really, because I entirely agree with what Penny has said. External strategic partners, of course, can add a lot of value. We know organisations who've got a lot of value out of working with people like IHI, Virginia Mason and Catalysis, and a whole range of others. And there's a lot for us to learn in that. Penny talks about the evaluation that's been done around the VM trusts, for example. But I would hate anybody to think that's the only way of doing this. I was fortunate to have a 30+ year career in the NHS and did a lot of different chief exec positions and tried to do this twice myself in 2 different big acute hospitals and didn't pay anybody externally to do it. And in fact, when I was chief exec of Bolton Hospital, we went out and found a whole load of people out of the private sector who wanted to share their learning for free. Everybody from British Aerospace to Warburton's Bread, who are a lean bread manufacturer, believe it or not. So, and then as Penny just said, we're not where we were 20 years ago. We've got huge expertise already here in the NHS. And what we want to do through NHS Impact is almost, we need to create some kind of matchmaking capability, I think. So those people, you mentioned the Q community, Penny, we've got the Improvement Directors Network, we've got organisations like the Academic Science Health Networks, my own organisation, old organisation Aqua. How do we pull them together, mobilise them into a coalition of the willing and the able, and connect them to the places that need the support and connect them to these big delivery priorities? And that's something I'm hoping Elsa's going to sort out for us in her new role as the National Improvement League.
Thank you, David. And I've already seen here in the chat, there's from Lindsay, who's saying they're already starting conversations across their local area, across different types of organizations and providers, and some follow-up to share and learn from Emma as well. How do we do this? So great on the discussion, and check on the Q&A. There might be some people worth contacting straight away. Coming to the next set of questions. Again, I'm sort of putting a couple together here, one from Haley Pinto and one from Salma Yaqub. And Haley is asking, to what extent are we also looking at environmental sustainability, net zero targets at the core of what NHS Impact is about, given how central it is going to be to the future of the NHS? And Salma asked the question, what about health inequalities? Are they going to be embedded and central to the way we think about improvement? David, if I maybe start with you on that one.
Yeah, absolutely, and we have had that conversation at the National Improvement Board. So I know there's a move to talk not just about the quadruple aim but the quintuple aim at the moment. I mean, for me, I actually think the sustainability question runs through all of the domains of the quadruple aim anyway, and I think we need to weave it into every single conversation that we have. But it is absolutely on our agenda, because unless we do something about the sustainability agenda, we won't have a health service left to improve. So totally agree on that point, and I think would be great, Malt, to get more contributions on that from people who are doing really good work. I know some places in the NHS that are very active on that, up in Newcastle and in other places, but it'd be great to hear more and learn from them. I think really keen to do that. And inequalities, absolutely. I mean, for me, every time I talk about the better health domain, it's about, I think sometimes we end up just talking about inequalities, and it's actually about raising the whole bar on health outcomes, so everybody's getting better health outcomes, but at the same time narrowing the gap and understanding the issues across our diverse communities and what's driving those inequalities and how we tackle them. And that's inequalities in health outcomes, but inequalities in access and experience too, and that's definitely part of the big picture aims for NHS Impact.
Great. Okay, I'm going to do one more question, then I'll hand to Penny, and then I'll move us on to the next section, particularly because I think we want to hear the very local and personal experience from Ailsa and Neil on this. But the last one I wanted to put to you, Penny, was that there's a couple of questions. One from Jem Ramazanoglu, I hope I got that okay, and Ruth O'Dowd, who is saying there are organizations where there's very limited belief or investment in improvement so far. It can be more junior people or managers who are trying to support this approach. What support can these improvement leads in their organizations get to help to influence their senior leaders? And then slightly different the question, but related from Ruth about that, working in challenged organizations where we are under a lot of pressure to improve our performance, the balance can be very difficult to move towards freedom of working on improvement versus performance. How do we get improvement to the forefront in those organizations? Not an easy one, Penny, but I'll give that one to you.
Yeah, thank you. And maybe this is something that we can come back to with Ailsa and Neil, because I think it really speaks to the reality of trying to do this. I mean, you know, I guess I would say that I'm seeing within Q the opportunity for people who are kind of finding common friends, people who can help them keep going when they're in more challenging organizational environments. So, you know, plenty of GPs where they might be the only GP with a particular interest in this. I think there are certain things that we can do just to help connect the isolated pockets of enthusiasm and work until the more supportive environment kind of comes into place. One of the things that I'm particularly excited about is how we're increasingly connecting the kind of frontline improvement community with the people who are leading this at director level, with, for example, the Improvement Directors Network in England, trying to think about how we can more strategically and systematically bridge that connection. And also just really excited with both NHS providers and NHS Confederation taking an explicit focus on improvement. And, you know, in partnership, I'm really excited by what that can do to help create a kind of sense of support at board level. In the meantime, that's not going to happen overnight, but in the meantime, it might help those people who are kind of struggling at a more junior level, not feeling supported, see the fact that actually the reality of doing this work is becoming more visible and is getting more attention at a senior level.
Great. Okay. Now, David, I know you need to leave in a few minutes for your CQC inspection. And any final reflection from you before you go from the questions you've seen and heard?
So just very quickly on the two last questions and a final comment, I guess. Yes, of course, we've got variation across the NHS. We have variation in everything. We know that as colleagues who work in improvement. So there are some places where the board's focus isn't an improvement one, where the weight of financial and performance targets dominate the agendas, and where maybe senior leaders don't have as deep a background. And we really need to work to encourage a reduction in that variation. And I listed, I think in my opening comments, some of the mechanisms that we need to use. We need to set a clear expectation that chairs, chief executives and boards will engage, will develop their own capability and will lead this. And frankly, NHS England need to role model that. I'm delighted that NHS England are doing that, that their executive are taking this seriously. NHS England are themselves carrying forward the self-assessment, and we need to work with NHSE, the regional office and the ICBs to set that expectation for boards that this is going to be a key way in which we're going to meet the service challenges that we face. And then as far as those organisations who are in the most challenged position, we've already got that on the agenda for a National Improvement Board conversation very soon. My personal experience is that the 5 domain framework can be really helpful, but we have to be realistic about where we start for organisations that are in a really difficult place. And in my own experience, it starts with that shared vision and purpose right through the organisation and giving back belief to colleagues, and with getting the leadership behaviours right before you can then move on into developing improvement method and improvement approaches. Final thing I would say, thank you for inviting me. This has been, I've enjoyed my CQC inspection, but this has been slightly light relief in that context, and some great questions coming through which say people are really engaging with the topic, Malt. So sorry I have to leave early. Thank you for inviting me, and thank you to all the colleagues who are on the call for tuning into this as well.
Fantastic, thank you, David, and fingers crossed for the CQC conversations. All right, so you've heard the helicopter view on improvement approaches, what the intention is, what the ambition is, some of the learning coming out of this, and what improvement can do, and what improvement means from Penny as well. So let's come to people who are actually doing this with their teams and have maybe the scars on their back, or also the enjoyment and exciting of having seen some of that. Elsa, let's start with you and your experience from Lancashire. Over to you.
Okay, thank you very much, Malt. So I would just really echo what David said, and if we could just have the next slide, please. What I'd like to talk to you about this afternoon is some of those elements that are in NHS Impact that David talked about. And David's just finished with a message for us about the importance of creating a compelling vision as we really take improvement forward and get the board ownership for that. So I do want to talk to you about how we've done that in our organisation and the work we've got planned next. And then really sort of, I just want to pick up on a couple of important areas that I think really help us to mainstream improvement, which was the focus we've been asked to look at this afternoon. And that's really designing and building a continuous improvement strategy for your organisation and building improvement. So I'm going to talk to you about some of the things that we've done, but I'd really like to learn from you too about what you've done, because I think when we stay in that learning space and we take the opportunity to learn from each other, then we do get that continuous improvement that we're all striving for. I want to then move on to talk for a few minutes about the importance of building improvement into an organisation's business infrastructure, because if we start to hardwire improvement into how we do business, then actually we start to mainstream it across the whole organisation. And then I want to finish by just talking to you about the work we've been doing in Lancashire and South Cumbria around building the foundations for improvement at system level, because that really is, when we're doing improvement right across our ICS, is where we'll really see the benefits that we're all striving to deliver. So apologies for the busyness of this slide. I'm not going to talk through it all, but I do know that the slides will be available for you afterwards. So I did want to put the detail in around how we went about creating our vision. And one of the things that was really important for us when we started this journey 5 years ago was to really understand our baseline and where we were. So what I would say to all of you just starting out on this work, or at the point that you might want to refresh it, we've just agreed as a board that actually we're going to use the self-assessment as an opportunity to refocus on actually what's our compelling vision for the next phase of work. We made no apologies as a board 4 years ago of setting always safety first as our culture. We knew that that was important. But right now it feels as though we need a different level and the next step in terms of maturity for improvement. And I think what we're really trying to build in our organisation is the understanding about how we can use improvement to create a breakthrough level of improvement in quality, safety, access to care, and our financial sustainability. And it's really understanding as a board what we need to do to be able to do that. So if you move on to the next slide, what we have got here is an outline of our CI strategy. So we've got the vision as a board, but actually our strategy is around how we go about delivering that vision. So we've done something slightly different, and I'd really welcome some challenge and debate and discussion on this. Quite often I hear improvement leaders say you need to adopt one improvement approach. I think what we've learned in Lancs Teaching as we've tried to really build our improvement capacity and capability to mainstream it is that actually we don't want an approach that is limited to QI projects. I think what I've learned over the years is that if you do QI projects, they can be really successful, but they often end up in a cupboard somewhere when the project's finished or when the person who was doing the project leaves. And we've really tried to build our CI strategy on the principle that everybody in our organisation needs to do their job and improve their job. You'll all be very familiar with that as a principle for improvement. So what we've done is been very clear about the complexity as you increase the bandwidth of the improvement work that you're doing. So where we're trying to do improvement across a whole system or the whole organisation, you need more improvement intervention, in my experience, than if you are just working with a single ward or department. So what we did in our strategy, and this followed a review of the evidence, somebody put a great question in the chat box from the NIHR about using the evidence base. We started by looking at the evidence, and what we were really struck by when we looked at the evidence for mainstreaming improvement is that actually if you can design a strategy and then an implementation plan that really means you're focused at improvement and the macro, meso and micro level, then actually you really do start to mainstream that improvement across your whole organisation. There's just two other things I wanted to pick out on this slide. One is the building capability strategy. So we know, and I'm sure many of you have had this experience too, that actually if you rely on the improvement team to lead and deliver a lot of the improvement, it will take us an awful long time to be able to get to the whole range of improvements that are needed across the part of the NHS that we work in. So what we've very much focused on is how do we build our improvement capability across our whole workforce. And the other thing that we've really majored on is our digital. So how do we really use digital comms? How do we use social media? But how do we use digital technology now? Because what we're learning is the more we can hardwire our improvements through the digital systems that we have and maximise those digital systems to help the greater level of impact we're achieving. So this is our plan on a page for our strategy. Our strategy is available, it's downloadable from our trust website. We've reported this to board, but really what we're interested in as we mainstream improvement is actually really understanding how we use measurement differently. So we've spent a lot of time in our organisation really understanding our data. So we do the diagnostics, so we focus our improvement effort on the right thing, and we're learning a lot about the importance of senior leaders framing the problem. So if we can frame the problem and work with our teams who have got the best solutions, then actually we're finding that we are increasing the amount of improvement work that we're doing. But the other thing I just wanted to point out in our strategy too is the importance of knowledge and evaluation, and also creating the learning system. We've got lots more work still to do on this, but one of the things we have made a commitment to is to evaluating our improvement programmes and hopefully, as we go forward, publishing our results and our work in peer-reviewed journals, because actually if we can build the evidence base, then we can really start to understand what it is from our improvement approaches that are delivering the impact we all want to see, and maybe what elements aren't actually helping us to deliver those improvements. And you'll see in here, I noticed Bob Lloyd's on the call with us today, and we have taken the learning from the IHI about the importance of building the will to improve. And actually we've got lots of will, in my experience, when you work with organisations for improvement. We've got lots of ideas. Where we often struggle is in the execution. So I just want to go on and talk to you about how we've done that across our trust. So in terms of our levels of competency for building improvement capability and expertise, we've really focused on trying to define the skills and experience needed to be a CI leader, what it takes to be able to teach CI, and then how we need to build the skill set across our workforce to be able to apply improvement to their everyday job, and then making sure that everybody across the organisation understands the fundamental basics of improvement. We've still got a lot of work to do in building our capability, but we're very specific about our strategy to do that. And then what I really wanted to show you here in this slide deck is just the level of improvement that we've got going on. This is just a small example, but I would urge you all to think about, as you mainstream improvement across your organisations and system, what work you have got that goes right across the organisation. So you can see here we have things like Always Safety First improvement collaboratives running. We have a programme of work that is specifically focused on improving flow that goes right across our organisation, and they are now starting to be expanded to across our whole system. We do the Flow Coaching Academy. I don't know whether anybody from the Flow Coaching Academy team is on here, but some of you will have heard me say before, the Flow Coaching Academy is really what enabled us to springboard our improvement. And somebody asked a great question about how do you do this if you don't have the resources? Actually, we were in that position. We are a challenge trust from a performance perspective, but also from a financial perspective. And we found it incredibly helpful to do the Flow Coaching Academy programme. We trained a team of 10 of us, and actually we were able to come back and establish our local Flow Coaching Academy programme. We've only shown you 4 big rooms on this slide, but we've now got 28 big rooms up and running. That they're all focused on our clinical pathways that are our priorities. So what we do have now is a critical mass of improvement work, and that's when I think when we got to 28 we started to think about actually the importance that had for us in terms of getting the improvement mainstreamed. And you can see there that we also do the Microsystem Coaching Academy, which basically is building our improvement capability at ward and department level. So I just want to finish now by sharing with you how we're really focused on mainstreaming improvement. If I could have the next slide. And this is really something that we're really excited about in Langston South Cumbria. Many of you know David works in our ICS too. And actually what we've done is bring together our improvement directors, our clinical leaders, and as Penny said, connecting in some of our Q community and others who are really interested in improvement to really understand what does it take to deliver improvement across an ICS level. So we're testing this out. If you just flick through the next 2 or 3 slides as I'm finishing off, colleagues will be able to see that actually what we've done is brought our teams together. You can have the links to see some of the work that we're doing, but actually what we're really starting to understand now at Malt, which is incredibly helpful, is how do we work with all levels of our system to be able to hardwire improvement into the system. So we've chosen frailty as our first test case, but what we're really starting to see now is that improvement focus shifting out of just our acute hospitals and right across our ICS.
Great. Elsa, thank you so much. And let's move on straight to Neil for his experience in Lewisham and Greenwich. And please continue to post your questions. I'll filter them and then we'll have time at the end. Neil, over to you.
Thank you very much indeed. And actually quite a lot of what I was planning to say has already been covered and far more articulately than I'll do it. But I guess what I was going to do was just, without any slides, I'm afraid, just run through my reflections from trying to do this kind of thing in various different bits of the NHS and elsewhere. We've talked a bit already, I think, about the key ingredients for an improvement system. And I think one of the great things now is that isn't really a mystery in the way that it might have been, 5 or 10 years ago. It's really well documented, I think, and I actually think the NHS Impact self-assessment tool is, one really good way of looking at that. We're using it, doing various workshops with the board and staff across the organisation to do that. So, what you need to put in place to have a decent QI system, I think, is now relatively well known. Really, it's an implementation challenge. And so I was going to give some reflections on exactly that. So firstly on method and capability, which we've just heard a bit more about. I mean, I totally agree that is essential to all of this, of course, is the improvement method. One thing I often see is that can start to look quite complicated, and I think organisations may suffer a bit from overcomplicating it right at the beginning and making it feel like a bit of a kind of priesthood. All that thing about different levels and badges and stuff can be really valuable, but it can also, I think, exclude people. So personally, I would keep the improvement methods as simple as possible, and build them up over time, rather than start with something complicated. The second thing on training, so I think the dosing model from the IHI is really important. I think very often I see, although people will have the different levels, as we just saw, it won't always be clear about what numbers you're trying to get to, and so be able to know whether we're succeeding or failing and have that real clarity about expectations. So I think a dosing model is key. I would be interested to hear from people where you've managed to not just see how many people you're training and check people have understood and kind of learnt what they're supposed to, but a way of reliably measuring how active people are after that. We've done kind of spot checks and that kind of thing, but the key thing isn't just what skills did people have when they were trained, it's are they using them, are they QI active? So that's kind of a bit about training and methods. The second thing I wanted to mention then was culture. I think we all recognise the essential nature of that to QI, improvement mindsets, data, leaders enabling change, and that has to be set, I think, from the top for it really to be effective. So it's a leadership challenge, and I'm going to come back to leadership in a second. So some hurdles, I think, then. So what to work on, I think, can often be quite a hurdle. Again, people have already talked about this. I think organisations often start with those kind of bottom-up, smaller scale projects. That's absolutely right. That's always got to be a big part of what we do. But I guess the theme today is how do we also work on the kind of high priority things for an organisation, so that QI, continuous improvement, is the mechanism for solving those big problems, not a thing on the side. So I think in organisations where people have tried to do this and where I've worked, so often there are a set of things that I think we don't quite get right with this. So even having decided what the high priority things are, I think often we have too many of them, so more than we actually have capacity to deliver at a given time, by quite a long way often, I'd say. Often some of the basics of decent QI aren't there, so people may not have like a clear logic model or driver diagram or whatever for what they're doing. Accountability, I think, is often really weak. So who's supposed to do what, when, and what happens if they don't do it. And I think the cadence often is just way too slow. So people often base things around a kind of weekly meeting or something, or a monthly thing, when if it's a really high priority thing, it's got to be daily, I think. So anyway, those are a few of the things I think we get wrong. It's a kind of lack of intensity, insufficient use of the method, and just trying to do too many things at the same time. And so what I think that often then leads to is a growing gap between the kind of expectation that people have of delivery and the reality of delivery. I think Penny was totally right that we've got to be careful not to overpromise on outcomes in a short space of time, but we do, I think, need to be tougher on process measures and on delivery of those. And again, I think, why do we end up watering it down in the way I've just described? Again, I think that's a leadership challenge. So I'm going to come back to leadership in a second. In fact, I'll do leadership right now because it's next on my list. So often the leadership of improvement is not right at the top of the organisation, or if it is, that leadership from somebody on the exec team will be a kind of in principle thing of saying, I really support this, but you somewhere further down the organisation need to go and actually make it happen. And I just think that doesn't work with QI. And we heard this, I think, earlier from David. It's got to be leadership in practice where, top leadership teams learn the method itself and become, advocates and practitioners of it. And that is just so different, I think, from the kind of leadership we expect in lots of other ways. People have kind of got to go back to school a bit to learn it. And that, unfortunately, I think just doesn't happen enough. That, again, I think speaks to the need to keep the method relatively simple so that top leaders can quickly learn something useful and start to get out and practice it. Because I think shortening that time between learning it and doing something useful, I think, is really critical. So the final thing I was going to mention was about looking at this longitudinally. So many of the organisations I've worked with or for, what I've seen is that people will say, well, this is really great. I'm glad we're having a big push on continuous and quality improvement. We did actually do something like this 10 or 15 years ago when X was here and so on. And what you tend to hear is this story of a kind of start-stop. There's the kind of license that's built, some resource put in and so on, and people go and try a particular approach, and then something changes, somebody leaves or whatever, and that approach disappears. Now, sometimes that's okay because the next iteration builds on the last one. I think very often that isn't what happens, and you take one step forward and one step back, and that just keeps happening over and over again. So I guess I think people should, certainly something I'm aware of, we all need to think, well, how do we quickly get this owned more widely, particularly at the top of the organisation, so that even if I leave or whatever, then it will still continue. And secondly, I think there's that point about impact. Even if we're not going to be able to shift all of the outcomes right away, and even if it takes 15 years to have a big culture change, I think we do need to set ourselves much shorter term horizons for impact, particularly on process measures, so that we can show that actually this really does work, get people involved right at the top of the organisation, and they feel it, and you don't get that kind of gap between expectations and reality in the same way. So those are my reflections, no more valid than anybody else's, and it'd be great to hear from others about what they've experienced.
Fantastic. Thank you so much, Niels. Thank you so much, Elsa. I'm going to start with a question that actually came up previously, but I thought it's still very relevant, which is the question about how do we involve patients and the public in the right way in our improvement approaches, which sometimes can be quite difficult to have them involved. Elsa, do you want to start with that, and then Neil?
Yeah, thanks very much, Mark. I can certainly share what we do, and I think there's always more that we can do. So we make sure that in the design phase of all of our improvement programs and our Flow Coaching Academy big rooms, that we engage with patients. So for example, for our Always Safety First, we had teams of our nursing and clinical staff actually go out and speak to patients on our wards. So we asked them, we took the learning from the IHI and said, from a safety perspective, what matters to you? And actually what our patients said to us, it matters that we always feel safe. So that's why we ended up with the name Always Safety First. In our big rooms, we invite patients. So some of you will be familiar with the Flow Coaching Academy methodology, and big rooms are focused on patients actually being in the big room with us. So patients sometimes stay for a long time if they really like the work and they've got the time, they'll engage with us every week on a weekly basis. But actually some patients we invite in to share their story, tell us what's important and what matters to them. And then we'll actually make sure that we base our improvement efforts around what patients tell us matters. And then finally, when we're doing our inpatient work, we have our microsystem coaching is based on our ward leaders hosting an improvement huddle, and they collect and seek views of patients in terms of what do we need to improve, as well as using our data.
Okay, and Neil, from your experience?
Yeah, I mean, I think that's an excellent answer, Elsa, and lots for me to learn from that. The only, I guess, additional thing I would say is in a programme in the last place I was working in Croydon, which was a system-wide thing in that borough, we worked really closely with the voluntary sector. They were like a key element of the programme, and I think they can often be a really good route into communities and real day-to-day experiences. So I think building the voluntary sector into what we do, I think, can make a big difference.
Great, thank you very much. Now, it's a question that's maybe a little bit unfair to you, Elsa, because you now have a foot both in your work locally, but also the work on NHS Impact sort of nationally. But sort of for both of you, what do you expect to be doing differently compared to what you're already doing with NHS Impact having been launched and being rolled out over the next month and year?
Okay, yeah, that's a great question. And I think it's early days, so I am more than happy to share through the Improvement Directors Network and other forums the work as it develops. I think what I expect to do differently, if we just take a moment to reflect, there's quite a few Generation Q fellows on this call, and I suspect some IHI fellows too. And actually, I feel really privileged to have had the investment in my personal development of improvement knowledge, skills, and the connections to those networks. What I expect to be doing really differently, Malt, is using the opportunities that NHS Impact will afford me as their National Improvement Director to be able to come out and speak to our community of improvers, so including the Q community, colleagues in Aqua and other places, to say, actually, what is it that you need that we can help provide and create, so that we absolutely, as Penny said in the earlier part of this webinar, connect our improvers together. So I'd be really keen to hear from all of you in terms of what you would like us to focus on as we really create the conditions for NHS Impact to be successful.
Great. Neil?
Yeah, thank you. Well, as I said earlier, we're using the self-evaluation tool thing because I think that's quite good. But one of the things I'd really hope NHS Impact can do is to use kind of peer pressure almost, bringing together chief executives, exec directors, and others, across organisations, to show those organisations that are a bit behind what good looks like. Because I do think people in the NHS tend to listen to their peers more than they listen to other sources of information.
Great. And Penny, can I put that question to you as well? What with the Q community, what's different? Where do we think we can help differently?
Yeah, I mean, the evaluation of Q perhaps reflects a kind of wider pattern of improvement where we're seeing people doing fantastic work at individual level, really demonstrating a lot of kind of benefit at team level, but not yet seeing the scale of change across the system. So I think that's the scale of the ambition for NHS Impact. And I think the ingredients to get there are just as you're saying. I mean, really unlocking greater awareness and understanding at senior level, the people who are setting the conditions for improvement locally and nationally. And yeah, I agree with you, Neil, that kind of peer influence is really important. If NHS England can kind of set the parameters and then get out the way and let kind of leadership come from within the service, I think peer organisations like NHS providers, like ConFed, and others can really help this feel more embedded within the service.
Thank you. Okay, one last question to Elsa and Neil, and then we wrap up. I think it's one from Helen Edelstein, who's asking, given the financial context, how can we build an improvement culture around health outcomes that are not immediately driven by cashable benefits? And I would add in-year cashable benefits on top of that. Elsa, what's your experience of that in Lancashire?
Yeah, so that's a great question, Helen. One of the things I haven't talked about is the work that we're doing across our ICS on Core 20+. So we're part of the IHI and NHS England Accelerator Collaborative, which is really focused exactly on what you've just said. How do we do the work that we know will take longer to have impact? So I think if we do this well, then we'll do both in parallel. We'll do the things that really do demonstrate those breakthrough levels of improvement, because we've got our focus in the right areas for in-year results. And of course, I'm not talking about a quick fix. I'm talking about really genuinely using an improvement approach to deliver impact. But we need to start the work that will take longer to on our reducing our health inequalities and really just improving the life expectancy and the quality of life for our local populations. And if it's helpful, I'd be very happy to talk to you offline about the work that we're doing and how we're doing that through our Population Health Academy with Andy Knox and Andrew Bennett.
Great, thanks. And Neil, for you, there's tension between savings and improvement.
Yeah. I mean, without a doubt, that's the case. I guess we all experience it, and inequalities is one example of one of those things. And integration. When I worked in Croydon up until recently, we've done a lot on joining things up at the local level. And again, can you make a very hard and fast business case for immediate return? No, definitely not. So I guess that really is about, again, leadership and vision, and being able to find enough senior leaders to create that vision and give people the headroom and the cover to do that longer term work. Is that an answer for people who can't find senior leaders who are willing to do that? No, it's not really. And so I guess that then comes back to what can organisations like NHS Impact and others do to unblock things where people aren't getting to those answers themselves.
Okay, great. Thank you so much. I'm aware that there's tons of questions that we didn't have a chance to get through, asking about involving local populations and individuals, voluntary sector and otherwise. Further questions around leadership and bringing people on board where they're skeptical or there's pressures, the use of crowdsourcing approaches, how to make sure that people are trained adequately and with enough depth and not just superficial, and so on. So apologies to all of you whose questions we couldn't answer. But I want to give each of our panelists another chance to say anything that sort of takeaways from the questions or the discussions, or indeed the questions they didn't have a chance to answer. If I start with you, Elsa, and then come to you, Neil, and then Penny finally before I wrap up.
Yeah, of course. So, Malt, I'm aware that there are some questions, as you said, that have been directed to specific panel members. I think we just need to make a commitment to answer those. So if we could work with you offline, I'd be very happy for the Health Foundation to share my email address. So if anybody does want to get in touch, especially around what we can do from an NHS Impact perspective, then I'd be really pleased to hear from you. And I'd be very happy to come and talk to any of your teams or networks, because how we connect and align behind this, as David said at the beginning, it's a once in a generation opportunity to do something very different to mainstream improvement. So I'm very committed personally to doing everything I possibly can to make that a success.
Fantastic, and thank you for that offer as well, Elsa. Neil?
Yeah, thank you. I mean, personally, I've really enjoyed this. It's been great to hear from Elsa and David, and I have a lot more confidence, I think, now in some of those initiatives that we can take forward across the system. So no, thank you, Elsa and David, although you're not here. I think I hear from a lot of people who find that they're just a bit stuck because they're not getting the leadership or the support they need to drive things forward. I think that's so often the challenge, and I think in those circumstances, I would say to people, try to get help from outside your organisation, because I do think there's only so much you can do to convince people just on your own. So I'd say, contact people like Elsa, me if I can help, or others, to be those kind of peer influencers. Don't just try and do it on your own.
Thanks so much, Neil. And indeed, I've noticed that some emails have already been exchanged in the chat as well, which is fantastic from examples for that. Penny, final words for you.
Yeah, I mean, gosh, this isn't exciting, but it's a long journey. It's going to be difficult. I mean, we've talked about the leadership challenges. We've talked quite a lot about senior leadership, but actually this is leadership at all levels, isn't it? And that challenge that I think we were touching on at the end, that need for ambidexterity, being able to look at the long term as well as the short term. Improvement has such potential to do that, but it's not easy. And so kind of making the space to work with peers to understand how to do that, I think is right. We need to build on the evidence and what other people are learning, because we just can't afford to kind of start from scratch. I'm really hoping that Q and the Health Foundation can help with this. By signing up to this webinar, we'll make sure that you'll then get the particular publications that perhaps have been mentioned here, and we can follow up, as Elsa says, on particular questions we haven't managed to get to. It's a conversation that's going to need to continue. Thank you.
Fantastic. All right. Well, thank you so much, everyone, for joining this webinar. I hope you enjoyed it and found it interesting. Our intention with the Health Foundation is to continue as much as we can to support how improvement becomes mainstream across the NHS and across health and social care through our work with the Q community. And more in that context, we've got a couple of publications coming out shortly, one around our evidence for improvement over the last decade more widely, and one focusing much more on the question of improvement across a local area, across a place. And a reminder, this webinar has been recorded, so if there's others you think who would really enjoy it, then we can forward it on once it's available in the next day or so. And you can obviously sign up for updates on our future webinars as well on the Q website or the Health Foundation website. With that, thank you again, particularly Neil, Elsa, and Penny. Thank you everyone for joining, and have a wonderful rest of the day. Thank you.
Thank you.